Welcome, Jim and Miss Elizabeth. And also last year, if you have watched our panel discussion, we have tackled the most critical role of nurses during COVID-19 times, and especially in the delivery of healthcare services in the primary healthcare and as well as specialized medical care. So this is the second part, actually, and the message has been very clear. Nurses, without nurses in the healthcare system, the world would fail. So to speak, the COVID-19 pandemic has immensely challenged the capacity of health systems worldwide. Healthcare facilities and health professionals, especially nurses, are overwhelmed with a number of symptomatic patients who actually need medical attention. So during the pandemic times, the nursing workforce is challenged with the issues of unequal and low compensations or remunerations. That our colleagues in the clinical field have also experienced violence, discrimination, and shortage of staff members can be felt in the clinical field. I was myself working during Corona pandemic times at the Corona unit at Helsinki University Hospital, and we really have a problem with the staff members who are trained with. We also have problems with nurses who are actually trained in tertiary level of care, in emergency and intensive care nursing. So, and while these colleagues are taking good care of Corona patients, they have also experienced some physical and mental burnout. And this has not been addressed properly, and this could lead to the nursing shortage. So our speakers for today will talk about that. And even access to equal access to vaccines. So among our healthcare workers, I was also vaccinating people in Helsinki, in Finland, and even nurses who are vaccinating people couldn't get the vaccine themselves, and they were less prioritized. So this is very unfortunate. And as everybody knows that the achievement of universal health coverage and sustainable development goals relies strongly to our nurses or frontliners in any level of care. So the State of the World's Nursing Report shows that utilizing advanced nurse practitioners will increase the access to promotive and preventive healthcare services in rural communities, especially to the vulnerable groups of the society, especially the minority sectors. So in line with this, these questions will be asked to our distinguished panel of speakers. What actions should the European Union Commission and the global community do to address the lack of recognition of this profession? What are the necessary measures to engage policy and decision makers in ensuring the sustainability of the nursing workforce? Should the world consider the critical shortage of nursing during pandemic times a state of emergency? So we will hear the answers from our speakers this afternoon. So we will be joined by our distinguished panel of speakers. We are joined by Ms. Elizabeth Ero virtually, who is the Chief Nursing Officer of the World Health Organization. Hi, Elizabeth. And we also have the active and feisty Ms. Annette Kennedy, who is joining us live here. She is the president of the International Council of Nurses. We also have Professor Katri Vehvilainen-Julkkunen, the chair of the Doctor of Health Sciences at the University of Eastern Finland. And she's also the nursing director at the Kuopion Yliopistollinen Sairaala, Kuopio University Hospital. And we also have Ms. Carla Asa, the Chief Human Resource Officer at the Charity University Hospital. And also the one and only Mr. Jim Campbell, the Director of the Health Workforce at the World Health Organization. Welcome, Jim. So if you have some comments or questions related to this afternoon's panel discussion, please type your queries or comments down below. Just click the Q&A button using the Zoom platform. And also we will entertain questions from our live audience. So I would like to show one video produced by Johnson & Johnson Nursing to show to our politicians and leaders why the world should invest in nursing. Let's take a look of this video.
During the Crimean War, more soldiers died from infection than in battle. Until a nurse introduced sanitary practices still in use today. When the scourge of polio hit the world, it was standard practice to strap down and immobilize patients. Until a nurse discovered that movement and physical therapy had far better results. In the 1950s, jaundice was a leading cause of infant death, until a nurse found that a few hours of sunlight could actually cure the condition. At the dawn of the AIDS epidemic, no one knew how the disease spread, so patients were kept quarantined and alone, until nurses defied convention and embraced them with compassion. During the Ebola outbreak, the disease was thought by many to be too contagious to treat, until a student nurse used what she had on hand, garbage bags and duct tape, to protect herself so she could care for others. And cerebral palsy robbed many patients of their ability to speak, until a nurse gave them back their voices. And I will always be grateful to her.
Well, I'm becoming emotional right now. That was very catchy and emotional. And those tasks continue to reflect in today's pandemic times. The 2-minute video says it all, why we need to continue to invest in nursing. So to proceed, Ms. Annette Kennedy, the International Council of Nurses has reported that millions of COVID-19 infections have been reported among healthcare workers. And tragically, unfortunately, 3,000 of COVID-related deaths are from among our nurses in 60 countries. The reality could be that the numbers are even higher, but due to unavailability of data from several countries, it could be even more. So that is very unfortunate. And we also fear that the long-term effects of COVID-19 would cause post-traumatic stress disorder and PTSD and long COVID. This will unfortunately have an impact to the nursing workforce in the future. And this report also highlighted the exodus of experienced nurses and mass traumatization of the nursing workforce during the COVID-19 times. I'm very excited to hear your report. And can you please tell us further about the results of this? Thank you.
Good morning here. Good morning, good afternoon, good evening to everybody around the world. Thank you, Flora, for that introduction. Thank you for calling me feisty. I better live up to that. And seeing as we're marketing countries for tourism, I'll market Ireland. That's where I'm coming from. So I bring you greetings from Ireland. I bring you greetings from the 27 million nurses around the world that I represent. This is a very important topic, the state of the world's nursing, the current state of the shortage of nursing going into the future. I'm not sure this is, oh, we're good. The global shortage of nurses and retention, and it concerns us all. This is a picture from a nurse in America, and because she was so frustrated, Alice is her name, and what she said was, I am standing up as an advocate for nursing. I am standing up for the shortage of nursing, and what I want to do is to tell everybody the real shortage. the real nursing shortage. And she said, I pledge to amplify these issues and to no longer keep quiet about our struggle. I will advance for change, for nurses to be treated with respect and to be paid their worth and with dignity. And as you can see, the issues that she displays on a cardboard sign. It's terrible that we have to go to these lengths to get notice, to get our politicians and our public to notice what is happening in the real world. Sorry, went too fast. I know that Jim and Elizabeth will talk about the State of the World's Nursing Report and the strategic direction by WHO. So I'm not going to dwell on that. But what I am going to say is that we went into this pandemic unprepared. No country was prepared for the pandemic, despite us knowing for decades that a pandemic would come. No country had resilient health systems. And no country had put in strategies in preparation for a pandemic. After 2 years, I hope we have learned some lessons. We had a shortage of 6 million nurses going into the pandemic. Nurses were overworked, they were overburdened, they were stressed out, but yet they met the COVID-19 pandemic with courage, with resilience, working 13 hours, working 10 days on straight, working without breaks, and working even more so without protective equipment. That was a disgrace. And then we come to see what's happening right now and into the future. And over the last 2 years, we have been reaching out to all our national nurses associations in 135 countries, gathering information about what's happening, about how they are finding the shortage of nurses, how they're finding the lack of PPEs, how they're finding the lack of support, whether they've been vaccinated, what countries are doing for the future, knowing that we have a shortage and knowing that we're heading to an even more severe shortage. And this is what it says. 74% indicated that they are going to increase the number of nurses. I will wait to see that implemented because it takes 3 to 4 years to register a nurse. So in the words of many people before, do we wait? Do the politicians wait? Do our governments wait to find out that this is the truth and we're heading towards a crisis of shortage of nurses? If we do, it's too late, like it was too late for our pandemic. 90% of countries surveyed report that they're extremely concerned about the nurses' workload. That's no secret. Absolutely no secret. Nurses are going home crying because they feel they haven't been enough, because they've had too many patients and they don't know if they gave enough service to each of those patients. They're going home crying because they're worried about taking the virus home to their families. They're going home crying because they have had to deal with so many patients that died without their relatives. You don't get over that. I worked in intensive care for many years. I didn't go through a pandemic, but I did nurse many patients who suffered head injuries, who suffered accidents, and who died very quickly and without warning. And I remember every one of those patients that died. So I can't imagine what those nurses will feel after this is over. 1 in 5 of our countries surveyed report an increase of the number of nurses leaving the profession. Let me tell you about that. We estimate that around 10% of the nurses across the world will leave early. They will leave for lower paid jobs. They're already leaving. The most experienced of our nurses from intensive care units and from specialist units are leaving. And what are we doing to stop them? Well, look, 1 in 5 of the countries surveyed report an increasing number of nurses leaving the profession. And of the countries surveyed, 2 in 5 said they had no strategy to retain nurses. I would safely say it's 0 out of 5 that has strategies to retain the nurses. So for me to say that we are going to bring in more nurses into the profession, but we're not going to retain our most experienced nurses is ironic, to say the least. You may have heard the WHO report yesterday about 115,000 healthcare workers who had died from January 2020 to May, June of 2021. We know because the data is not being collected systematically across countries, and we have tried ourselves to collect it, but it's not being collected systematically. It's not being divided by professional grade. It's not being divided by gender or by age. Only a few countries are collecting accurate data. So how can we tell how to prevent the infection going from nurse to patient, patient to nurse, nurse to other healthcare workers in between each other, or whether it's coming from community? And how do we provide them with occupational health remuneration? And we're not. Of that 115,000, the majority will be nurses, because nurses make up 60% of the workforce. 90% of those are women. We know that 6 to 10% of COVID infections are among healthcare workers. In fact, in the very early days, it was up to 15% and maybe up higher. Many of them will have long-term COVID infection rates, will have long-term effects. 80% are reporting mental health issues. Stress, anger, anxiety. And now in the last, because we pick these data up probably every 2 or 3 months, it's up to 90% at the moment. So you can imagine anybody that experiences anything to do with COVID patients will suffer mental distress. Increasing number of violence among healthcare workers and among nurses, from disinformation, misinformation, from thinking that nurses are bringing COVID out into the public, that they're not, shouldn't be given vaccines because people don't want to be vaccinated. That to me is a disgrace. So on the one hand, we have people who have a choice of getting vaccines and other people who are crying out for vaccines. Where's our humanity? Where's our equity? 20% of our NNAs surveyed said that they're still short of PPEs. They're still using the same PPEs, and they're still making their own in some countries. It's a shame. So why are nurses leaving? Very simply, they're overworked, they're burnt out, they're stressed, stretched. How long can they go on? They were quite prepared to do it for 3 months, for 6 months, for 9 months, 2 years. How long more do we expect them to give their all? Short already. A lot of their counterparts going out sick, a lot of their counterparts with long-term COVID and with mental stress disorders and physical. Money. Some nurses aren't even being paid in countries. Some nurses are unemployed in areas where they need them most because there isn't the funding in the health systems. What are nurses doing? They're voting with their feet. In the US right now, Nurses are leaving their current jobs and going into agency work because they can make 3 and 4 times the money that they're currently making in their job. What does that do? A, it gives them that they have less responsibility because they're not in their workplace environment. They're coming and going to various areas. Second, they have enough money to work less hours. Working less hours means you're taking even more hours out of a depleted system. That's the United States. Mm. But they're also leaving from every other country for jobs that are less responsible, that are less stressful, and that they can sleep in their bed at night. And added to that, we have nurses right across the world who haven't the choice of being vaccinated, or other healthcare workers haven't the choice. And yet we expect them to go in and deal with patients with a deadly virus. When I said about 115,000 nurses and healthcare workers dying, what I meant to say was, where are the investigations into that? A plane crashes. Rare, but it crashes. There are investigations. If a plane crashed every day from the start of COVID, you wouldn't even wait a week for the aviation industry to close down, for the world to close down, and for investigation after investigation until they found the source and dealt with it. So as I said, we went into this with 6 million nurses short. The report also, and our research has shown that in the next 10 years, less now because it's 2030, almost 4.7 million nurses are eligible to retire, mainly from Europe and North America. That's 10.7 million if we don't do anything. Added to that, you have 10% is the information we have received from our National Nurses Association in 135 countries, say that nurses are leaving and plan to leave even before they're due to retire. Add that, and you have 13 million nurses. We currently have 27 million nurses. So are we looking at half of our workforce? If there's no interventions by government, by policymakers? Is this a crisis worse than COVID-19? We all have a responsibility. There will be no health system without nurses. I can guarantee you that. And I don't want to live in a world where there is no nurses to look after me as I head for old age. So Aging Well is a report we brought out, and I'll just go ahead. We need to keep these people in the workforce. They have a lot of knowledge, they have a lot of experience, and these are the 10-point plan that we came up with. It's very simple. You find different ways of keeping elderly nurses in the workplace. They can't be at the bedside all the time. They have, the same physical and mental issues that anybody else has. Flexible working, what's to stop us giving different hours of work for them? What's the issues of going to occupational health and saying, well, you may not be able to work here, but you could work there. You may be able to mentor students, or you may be able to be a prospector. You may be able to look at your income and say, this is the amount of hours I need to work, and these are the benefits I would get. You may be able to help young nurses in succession planning, in leadership. There's so many things that they could do. And during COVID-19, a lot of retired nurses came back into the workforce. Did we keep them? No. So I think I've revealed that we're in a crisis situation. So what do we need to do? Effective monitoring, and probably well over time. We need to support, we need to document what's happening. Particularly because what we are seeing now, and we will see in the next couple of years, is the shortage of nurses. Wherever there's a shortage of nurses in high-income countries, you will see them actively and aggressively recruiting from low-income countries. And they're already doing that. Just to make sure that we at home in our own country are okay, the same as we're doing for our vaccinations. And we need regular labour market analysis of the workforce. We're not doing that. It's easier not to know. Avoiding the issue is good. So finally, and we can talk about this, I'm sure, later, because I don't want to take everybody else's time up. What am I doing? Reframe. We can look at different ways of working. Nurses reached out, during COVID, reached out to the most vulnerable in society with different models of care, making sure, because those people were afraid to come into the hospital, afraid to come into health centres, so they reached out to them. We can do so much different. We can do so much with technology. We can do so much with enabling our nurses to work and to work well. So it's about support, it's about investment, it's about changing the way we work, it's about different models of care, and it's certainly about putting more effort and investment into community care as opposed to treatment. Prevention is always better than cure. And just a final thing, our conference is on from the 2nd to the 4th of November virtually, so you're all welcome. Thank you very much for listening.
Thank you, Annette. It's really very unfortunate to hear that we need to continue to lose the lives of our colleagues working in the clinical field just for the society to realize how important the nursing profession is. And our colleagues are actually starting to live day by day. I can feel it. I'm working, I can see it through my eyes in the clinical field. They're really burned out, physical and mentally burned out. And I hope that it will not happen in the next few years, because we cannot survive without nurses. And just to give you one good example from the Icelandic Nurses Association, and some links for our government officials to also follow that. Icelandic Nurses Association negotiated through government officials that nurses can only work 90% and get paid 100%, so that they get more rest and day offs. They can spend time with their family members and also find time for themselves to relax. And that would be a good link, a good suggestion for our policy and decision makers. And Annette just said a while ago that we might be in a plane crash. And so I hope that we can correct the plane crash and we can land together safely. This is by saving our nurses working in the clinical field. And hopefully, for the past 2 years, we have also learned our lessons. And Annette also mentioned about working in an agency, and that's actually a reality, because nurses get paid very well, even 30 to 50% higher than their hourly rates. And that's the reality. And I have done that myself for the past 2 years. So speaking about money, of course, money is involved in the budget system, and also increasing the salary of nurses. So according to Ms. Carla Iso, according to the OECD in 2017, better salary level will actually influence job satisfaction and attractiveness of the nursing profession. That's the reality. And another unfortunate fact is that most of the countries are actually paying nurses below the average level than based on the law or the wage of the country. And many nurses have actually cried out loud towards proper remuneration during the pandemic times, because the work demand is incongruent to the level of salary they received. And in some countries, nurses are even promised, okay, we will raise your salary, we will pay you with hazard pay, but they don't actually receive the money that they deserve. And some are even threatened, if you will leave the nursing profession, if you will leave us, if you will leave the institution, you will not be able to get the hazard pay and the salary that you deserve. And you will not get the certificate of employment. And that's very unfortunate. And so Ms. Carla Iso, having didactic experience in the field of labor policy and regulation as a lawyer, what factors prevent most countries actually in raising the salary of nurses? And do you consider these factors as a critical factors causing critical shortage of nursing during pandemic times? I'm very excited to hear your point. The floor is yours.
Yeah, thank you, Flora. Thank you, Annette, for the inspiring talk. Welcome from my side. I'm not a nurse, I'm a lawyer and an economic person, and that's why people are asking me to talk about money. But I chose to go for a broader approach because I think money is only one aspect in the system, and Annette talked about a lot of issues I will talk to as well from a German perspective. I can only take over the German perspective. And as I can see, in Germany, the law was changed in the middle of the pandemic to organize money to the nurses. So there's a new law since 2020 that every nurse that works in a clinic in curing or caring for a patient gets paid 100% by the system. That sounds amazing, doesn't it? But the system itself didn't change. So the money that's in the system is still the same. So it's been taken from other professions, from the doctors, from paramedics, maybe from the patient itself, because the cure gets less. So I think thinking about money in the system is necessary to talk about the whole system, not about only one profession, because nurses are not the only profession in the system. And the system changes a lot due to technical influences. Digitization can be used better to improve processes in direction of the patient. And if you improve processes, you have to improve the roles and the competencies of all people in the system. And that's the second point I want to make. In Germany, we have normally nurses being taught as apprentices. And now, since January 2020, it's also possible to study nursing in Germany. Wow, it's a long time that we got this. But now we have the system and the possibility. But the system didn't change at all. People who are studying to be a nurse, they have the same job, the same role and competency model as all the other nurses as well. So there's no change at all. When Flora mentioned in the beginning that nurses are vaccinating, I was smiling a bit because in Germany it's not allowed. Only doctors are allowed to vaccine. So the system is very old-fashioned. It's bound by cliques and very old systems. The government doesn't change the system in a whole perspective, but it only changes punctually by changing things for some professions. And I think that's a huge problem, because if you look to the crisis, it showed that the multi-professional work in the clinic was the success factor. People were working together in a way they never did before. They changed and shared their jobs, and they were working in a very compound and profound way. And I think it would be awesome if we could enable people to work in a fully functioning system, rearranging competencies and roles of the people in the system. And if we encourage the governments to do so, I think we have the chance to, one, finance better, because if we work on clear and efficient processes, it makes less burden and stress for the people in the process. It gives better results for the patients, and it costs less, which is important because we can't just deny the financial factor. I want to give you an example. Annette said that people are voting with their feet, and it just happened in Berlin. We had a strike for 30 days just recently. Why? The nurses said that they are fed up, people clapping on their successes. People were clapping and then nothing. So that was what frustrated people even more. And they said, we will leave the job if you don't do anything. And what happened? Nothing. So we decided, and I want to give you the example of what we decided to do. We talked to the trade unions, and we started having an agreement which addresses many of the fields Annette was talking to, like violence in the job. This makes people leave the job. like, yeah, it's a very heavy issue, like being stressed out because you have to do too many patients at a time, being not happy when you go home because you don't have the feeling that you were all right, you didn't work properly, you have the feeling that you only did part of what you could have done if you had more time, more possibilities. So we made caps, how many patients a nurse can treat in a day, in a shift. And if she or he has to treat more patients in that shift, then she or he gets a free shift to get recovery. We put psychologists in the ICUs to take care of all the people that have to handle death every day. So they can work with them together, that the psychologist can take over part of the patient and the relatives' work, and that they can, just as having a cup of coffee in a very rare break, to talk about what they just experienced and to get a bit of a relief and to be overviewed and overseen if there's more to be done. Third, we have the agency work as a problem. So we did a cap on this too. We have at the moment in between of 30 to 40% of agency workers in the surgery, in the field of surgery, which is far too much because people are not instructed on working in this surgery room. They are not part of the team. They choose the best shifts, they come, do their job and leave. There's no loyalty to the team. So that's a huge problem for the satisfaction of the people that are there. And that's one point that touched me a lot when Annette was speaking. We are looking to address people to come into the job, but we don't take care of the people that are already in the job. Because if nurses in Europe leave their jobs after 7.5 years in the job at the moment, we need to keep them. We need to make them happy. We need to make them efficient, that they go home and have the feeling they did the best job they could do. And that's something HR and I think the companies themselves can do, supported, sure, by the government. But the first step, I think, needs to be made by the system itself. So that's why we at Charité went into this agreement with the trade unions, organizing the cornerstones of avoiding violence, reducing the impact of agency work, organizing shifts that are possible to be worked on, and paying our own people more money if they do shifts that are not regular. If we have to take them out of the free, why give the money to the agencies? Give it to your own people and make them flexible and give them possibilities to work in a different way. And I think waiting for governments to change things might be a long wait. And I think we have to start doing things by ourselves, going forward with very good examples and helping our people to be proud of what they do again. And if they are, I think they will go out and address more people to come into the job. And that's what we are there for, which is HR and the nursing field in the clinics. Thank you for your attention.
Thank you so much, Ms. Carter. I'm just interested to hear the comment from Annette, hearing that nurses couldn't even vaccinate here in Germany. It's only done by doctors.
I am absolutely shocked because I would say safely 80% of the vaccines in Ireland were done by nurses, and right across the world, the vast majority of vaccines are done by nurses. So I am shocked.
Yeah, because also in Finland and some parts of the Nordic countries, nurses are tasked to pass a test so they can vaccinate the people, and their competencies are confirmed, so and they can go to the clinical field and vaccinate people safely. Nurses are trained actually during the first years to inject intramuscularly. So I'm teaching students to do that. So why not nurses can also do that? Mm-hmm. Yeah, so Ms. Carla actually mentioned that instead of the money goes to the nurses, it actually went to other professions. So why we couldn't find money for nurses, which comprise up to 60% of the healthcare professionals, and that's really, really, really unfortunate. We should find ways to improve the remunerations and salaries of our colleagues. Although the medical field and the nursing field is a calling, but it is time to translate the recognitions into proper remunerations. We really appreciate the banners, the clubs, and the grandiose lightings, but unfortunately, we also have bills and rents to pay. So we need salary raise and proper remuneration. So, Jim, who is joining us virtually, the World Health Organization has declared this year as the year of the International Year of Healthcare Workers. So the global community continues to suffer from this shortage of healthcare workers even before the COVID-19 pandemic. I would just like you to explain for those who don't have a background in the health workforce and in the healthcare field to understand where is this shortage actually coming from and what has been the impact of COVID-19 on healthcare workers, especially nurses, and how would you relate this to the glass half full model, which I'm really interested to know and learn myself as well. The floor is yours, Jim.
Flora, good morning, and good morning to fellow panelists and Elizabeth also virtually. Very, very interested to hear the discussion going on this morning. Indeed, this year, the International Year of Health and Care Workers, resulting from the realization by ministers of health, member states around the world, the dedication, the role, the responsibility, the sacrifice of all health and care workers at the forefront of the COVID-19 response. And that continues on from what had been a first the year before on the International Year of the Nurse and the Midwife. So very much a recognition of the role of health and care workers, health service delivery. What do we actually mean by the shortage that we are referring to? And what's the impact of that? In terms of our global labour market, it's very much around trying to understand the balance between supply, need, and demand. The population needs for healthcare services are rising everywhere. The demand to expand universal health coverage for all populations, the response to the non-communicable disease epidemics that we're seeing around the world, aging and the demand on the care sector that we're seeing in high-income countries in particular. So there's an increasing need for health services, and therefore there's an increasing labour requirement within that. The demand, though, is stimulated by the economy, the economics, the money, the financing. And what we're seeing is that the high-income countries around the world have got enough resources and revenue to be able to invest in the recurrent cost of wages. And so they are able to create additional jobs and to absorb more staff. Or conversely, those in low and lower middle income countries where the government expenditure on health is constrained, especially as we're seeing now with the impact of the pandemic worldwide on the economics, revenues, tax bases, jobs, social protection, less money available to go into healthcare services and less money to go into the recurrent cost of wages. And that's where we see economic demand is not stimulating the creation of jobs. And so graduates may be coming out of some countries. There's a population need. We've got some supply from education. There's a population need, but there isn't the economic demand to stimulate jobs. And so you've got unemployed nurses alongside population things. So you've got to understand the shortage is not just necessarily in the number of people, but it's also a shortage in the fiscal space, in the revenue that governments will invest into health and health services. And then it's how you ration that revenue, how you distribute that revenue to make sure that you put it further forward. The additional shortage we then have is what colleagues have been talking about this morning, which is when you are having to provide routine health services and respond to an emergency, a shortage, your existing workforce is going to be spread thinner. So 2/3 of countries have reported that the shortage in sufficient staff is the biggest impact on the managing the pandemic, because they can't be both. Health workers, only have so many hours they can work, can only be in one place at one time. And now we're asking to vaccinate the world. 40% target by the end of the year, 70% target by June of next year. And it's interesting to see the scope of practice around who can vaccinate. We're seeing in some countries, vaccinators now being trained in 2 to 3 months from the lay population, not even a clinical professional, so that they can be part of vaccination teams. So how does this workforce routine services manage the pandemic and also vaccinate the world? And so we've got a shortage in the practice environment today. That shortage compounded by all the factors we've heard: the stress, the conditions of work, the pay, the remuneration, the respect, etc., etc. Annette mentioned momentarily the joint statement that we published on the estimated number of deaths worldwide, and with ICN, with the World Medical Association, with the pharmacists, with other organizations, ILO, Labour, OECD, many other civil society groups, with 3 clear calls to action. First is that reporting, data and reporting must be better. Annette mentioned this. If we are going to take policy decisions, policy actions, if we are going to protect the workforce using our science, we need better data today. We cannot continue with the level of reporting that we have and still make policy decisions. Secondly, we must ensure decent work conditions. I absolutely agree with what Carla was saying. We need to invest in the people who are there today, the people who are working, the people who are on the ships, in the hospitals, in the facilities, in the management. So we need to do decent work, and we need to ensure that includes pay. We've seen the nurse strike in Berlin, yes, but we've seen strikes and protests in over 84 jurisdictions in the last 18 months. There has never been, since records have been kept, that level of labour protest. And it's indicative of this stress. It's indicative of the work conditions. We must take action on that. And then thirdly, we must take all necessary measures. The joint statement that all health and care workers around the world, especially those who are at the forefront, are given the opportunity to have the vaccine against COVID, and are given that opportunity immediately. We need to ensure that these health and care workers are protected in their environment. So, Flora, I think you've got to look at this question and the glass half full model and the optimist, the pessimist, against the evidence. We went into the pandemic without the necessary financing in fiscal space, huge underinvestment in employment and the education supply around the world to do this. So we went into there with an existing shortage. The shortage of investing in the workforce today and the shortage of action has meant that we've got this real problem around retention and attrition of the workforce, and so that overall numbers against population needs going backwards, and that we've got to invest in decent work. At the end of the day, though, there is some excellent. Carla's just given us some real practical examples of actions that can be taken within a national setting, within a policy setting, to make improvements straight away. Some of the COVID-19 impact has forced us into innovation and changes in scope of practice, changes in team behavior. And we need to capitalize on those so that the whole team and the scope of practice is empowered and enabled. So I think we will eventually come out of this with healthcare systems that have greater appreciation for the scope of practice of nurses, greater appreciation for the scope of practice of all occupations in a team-based approach, and that we may therefore be able to get something. But at the moment, we're real concerned that not enough is being done to stem these current losses. So let me leave it there. It's a great conversation on a Sunday morning, and I wish you, those who are in Berlin, to enjoy the rest of the World Cup. Thank you.
Thank you, Jim. It's very sunny here in Berlin. Let's give applause for Jim. Yeah, it's very clear as the water, that nurses are at higher risk of contracting the COVID-19 virus while taking good care of these patients. We need to give nurses decent working condition, and we need to also decrease their workload in such a way that they don't get stressed physically and mentally, or they experience physically and mentally burnout. And Jim mentioned that the healthcare workforce is aging, and the aggression of the developed countries to recruit nurses from low and middle income countries are causing imbalance with the health workforce. And joining us also live virtually is Ms. Elizabeth Iro. Part of the independent role of nurses is to be able to make decisions towards patient care. And unfortunately, nurses are prevented from making decisions to their patients, especially in countries with significant hierarchical structures. Nurses are, as discussed previously, should be vested power in policy and decision-making process, especially with higher educations, who went for specialization programs like master's degree programs and doctorate degree levels as well. So in order to understand the impact of policies on nurses during pandemic times, so that we can come up with a strategic direction. So the global strategic directions for nursing and midwifery. What is the global situation of nurses in the field of education, jobs, leadership, and service delivery? So what leads to a shortage of nursing workforce in these areas? Can you please give us some info about that, Ms. Elizabeth? And the floor is yours.
Thank you very much, Flora. Greetings, everyone. It's really lovely to be on this panel this morning. Greetings to my fellow panelists. Now, last year, as we know, the 200th anniversary of Florence Nightingale's birth, WHO shone a light on the work of nurses and midwives worldwide by designating 2020 as the International Year of the Nurse and the Midwife. Now, it was also in recognition of the work and contribution nurses and midwives make towards universal health coverage and the Sustainable Development Goals. WHO produced the State of the World's Nursing 2020 report, published in April that year, highlighting the global issues facing the profession: inequities in the distribution of nurses around the world, a need to accelerate nursing education in order to respond to the changing technologies and advancing models of integrated health and social care, a requirement to create 6 million new nursing jobs by 2030, and the promotion of leadership so that nurses can competently play an influential role in health policy formulation and decision-making. We knew in April 2020, before the COVID pandemic took its stronghold worldwide, that we did not have enough nurses. We knew that each year, 13% of nurses migrate to work overseas, many leaving countries that could ill afford to be without them. We knew that many nurses were nearing retirement age, and critically, we knew that more nurses were leaving the profession each year than were joining it. We also knew the reasons why nursing was tipping into a crisis: low salaries, unsafe working conditions, insufficient access to training and education, and increasingly heavy workload are everyday realities for nurses everywhere. Approximately 90% of nurses are women, many of whom are the primary carers for their families, juggling pressures at work and home life. The reality on the ground is that in 2020, nursing was already in a crisis, and governments had failed to recognize the implication that this would have and address them sufficiently. Data gives us the information and the evidence we need to build our workforce to meet the needs of our communities. How many nurses do we need? Where do we need them? What skills do they need to have? It is critical that countries have robust processes for collecting and analysing data through a health labour market lens, so that it is possible to prioritise our investments in nursing to the areas where they are needed most. Worldwide, the education of nurses and midwives is not standardised and ranges from a certificate in nursing to a bachelor degree program. We advocate for driving forward a competency-based education that is accredited, where standards are global and the quality of care and the safety of patients is never compromised. Nurses have told us that they leave their jobs because they are overwhelmed and working in unsafe or unsupported environments. Many feel they do not receive a fair wage for the roles that they are trained for. Earlier this year, it was reported, as Jim mentioned, over 80 countries were calling for strike actions because of unsafe or unsustainable working conditions. It is so important that governments listen to the voices of their nursing workforce and work together to address these fundamental issues. Senior nursing leaders must be contributors to the discussion and decision-making processes in government around health workforce planning and healthcare strategy. WHO strongly encourages nurses to work alongside our partners, economists, lawyers, environmentalists, and politicians, and contribute at the table as equal partners with unified goals. From the State of the World's Nursing Report, we know that the presence of a government chief nursing officer and national nursing leadership programs are associated with a stronger regulatory environment, a more educated and better governed workforce, and safer patient care. Currently, 1 in 8 nurses was born or trained in a country other than the one in which they currently practice. The WHO Global Code of Practice on the international recruitment of health personnel urges prioritization of support and safeguards for the countries with the greatest vulnerability, including greater investment. It strengthens implementation, financing, and monitoring is critical now more than ever, as we see the effects of nursing migration across the world. I ask that we reinforce the implementation of the World Health Organization's Global Code of Practice. But alongside this, it is essential that countries, particularly high-income countries, who recruit large numbers of nurses from overseas, do not rely on a workforce from overseas as a long-term solution to their nursing workforce crisis. Instead, they must focus on creating education programs of their own that support the recruitment and retention of nurses from within. In May this year, member states endorsed the resolution at the 74th World Health Assembly, the first one in 10 years, to strengthen both nursing and midwifery by investing in education, jobs, leadership, and service delivery. The resolution, informed by the Global Strategic Directions for Nursing and Midwifery 2021 to 2025, is supported by 12 policy priorities that strengthens developments in both nursing and midwifery and ensure further investment in nurses and midwives as leaders at the most senior level in government. The Strategic Directions for Nursing and Midwifery offers governments a roadmap to move forward with strategies that ensure nursing and midwifery careers are not only attractive to young people considering their work options, but they prioritize safe working environments, access to education, training, and fair pay. It is these factors that will make people join our profession, and most importantly, it is these factors that will keep the nurses in the jobs that they are in today. Our communities cannot afford to face a future without the workforce to look after them when they are ill. But if we fail to act, if we fail to prepare for the future, and if we fail to address the critical issues we face in nursing and midwifery today, we will fail the very people we rely on to keep our communities healthy. As we plan our complex work around the implementation of the Strategic Directions for Nursing and Midwifery, WHO will endeavour and continue to build strong relationships with government chief nurses and midwives, ministries of health, and our key partners, and global communities of nurses and midwives and others, all who bring expertise, experience, knowledge, leadership, inspiration, and hope to some of the biggest challenges that our profession has ever had to face. It is critical as we move forward with the implementation of these strategies that as a global community and partnership, we are aligned in our efforts to support countries in their policy priorities in respect of education to address the global shortage, building leadership capacity, and expanding the provision of our practice and service delivery. We are committed to report on data on an annual basis to the National Health Workforce Account and update on the national and the policy dialogue and decision made through the Government Chief Nursing and Midwifery Officers Forum and the ICN and the ICM and WHO triad meeting held every 2 years. We cannot do this work without strong and effective partnership where we can make wise decisions based on data, evidence, and context. There's my overwhelming hope when we emerge from this pandemic that we build and strengthen our health and care workforce by working together, by recognizing that our successes are not defined by our individual skills and professional capability, but how we combine our knowledge and work with one another at every level to create better health for all and to keep our communities safe. This requires commitment from all parties, including member states and health partners at this World Health Summit, to invest in the systems and measures needed to promote health across the life course. This includes investment in nurses and midwives in order to protect health and deliver the care and services affordably, effectively, and safely, exactly when they are needed, no matter a person's gender, nationality, or wallet size. Health for all is at the heart of WHO's work to create the environment and means needed for each and every person on the planet to achieve the highest attainable level of physical and mental health and well-being. I thank you.
Thank you, Ms. Elizabeth. While you are speaking, I was able to get 3 points from you. One is that the education is not standardized. Actually, we are very lucky here in Europe that we have a European Union Directive 55, which is the sole basis of our nursing curriculum. And I'm currently making one of the nursing curriculums also in Finland, and we will be opening the English program next year, hopefully, so we can educate more nurses who have foreign background, so they can also practice their profession. And the second point you mentioned is the World Health Organization Code of Ethics in recruitment of international health professionals. And some countries, high-income countries, they recruit nurses with already registered nurse background. They have the competencies, they have a license to work, but when they come to, for example, in Europe, they are not able to practice their profession because the employers or the recruitment agencies are not helping them to get to the goal of being a registered nurse. So we are losing actually competencies or competent nurses who can use their skills. And the third point you mentioned is the gender equality. And we always encourage that in the board members, that the board members should comprise of at least 60% of women. So women also have a power to give their voice when making decisions. So and Professor Katri, let's talk about evidence-based practice and nursing, evidence-based nursing. So after hearing those policy discussions and reports, what are the empirical studies conducted supporting the current global shortage of nurses, both in developing and high-income countries or developed countries? Do we have a weakening support of nursing science in the scientific community? So I'm giving the floor to you.
Okay, let's get started. So, ladies and gentlemen, it's a great pleasure for me to be here today and give my talk, short presentation about the evidence, what we know about the situation. And it's a huge task, to be honest with you. So I come from Finland, from the University of Eastern Finland. I also I'm a professor there, and I'm working also at the University Hospital side. I have a part-time position there. So we have a medical school as well as nursing, big nursing school in Finland, in Kuopio. But to come to the point and speak after our esteemed colleagues, so I will get my program. Yes, this is working now. Sorry about that. So let's come back to the issue what we have heard today already from Annette as well as from other speakers, that actually we know the situation even before COVID-19, that nurses are actually leaving the profession because of stress, burnout, anxiety, work environmental issues, as well as when we talk about the digitalized world. So many report also about unhelpful technology that is not easy for them to grab. And we have heard about the figures. So I have the global situation here over approximately over 7 million in a few years, 2030. And one important issue, what I see, we also have international programs in our school, in the University of Eastern Finland. And when looking at the situation with migrating nurses, what actually Elizabeth mentioned in previous talk, so that we have the migration is from low and middle income countries, and high-income countries are getting nurses from there. But what is the situation in those countries? So this is a question. The other issue is in high-income countries, what was mentioned here, that the retirement age is high. I mean that those that are retiring is extremely high in high-income countries, and how we actually take the advantage, how we use those that are close to retirement, or they want to continue part-time, or what can we do with this issue? So this is where we have been. And then when we come to what have been the research on, so I always refer to this European level RN forecast study. That is a huge study with all international experts, but we have the European report, how we can actually strengthen the health systems through nursing from 14 European countries. Our university and our university hospital was also involved in this study, led by prestige research experts from Europe as well as from US. So this is something that has shown that there is evidence when we have a good staffing ratio, so it is impacting the outcomes of the patients, even having the impact on mortality of the patients. So there's high evidence on these issues, as well as, of course, what the staffing means to appropriate staffing levels means to the health workers, as well as for the organization. So this is a huge discussion going on. But then we come to the issue, what has been, I'm repeating the same what was we discussed earlier already today. So it is the working conditions. Carla, you used the word decent working conditions. So that is what it is expected. The number of patients are increasing, of course, because of the issues there's a demand. We have elderly patients. We have multi-problematic patients that have different comorbidities. So it's really, and we have a high-tech, excellent medical possibilities to help people. So then there's the violence in clinical settings, retirement, I mentioned. Then the difficulty in retaining new graduate nurses. Even in Finland, we have a very heavy discussion at the moment. So the figures that Annette showed and also Elizabeth was referring are quite the same in a country like Finland too. And faculty shortage is one issue, that have we competent researchers and faculty members to teach actually our future nurses. So this was what we heard already. I know the time frame, the time restrictions, but actually there is this nursing. We have experiences that nurses have the challenges really to deliver safe and good care to the populations. And especially those nurses that are working in rural and community settings, they have really, really big issues on their hands. Then there are some signs that even when I'm coming from a country like Finland, so there might be some discrimination of these that are internationally educated. So the nurses are in this kind of a situation. And of course, nurses are working everywhere. So also in the underdeserved places around the world. So that's important to remember. But then, Flora, you asked about the research evidence and what it is telling us. So now when we look at now I'm just referring to nursing field and the publications that are in our science citation index. So we have over 130 internationally peer-reviewed journals in this field at the moment, reporting a lot about different aspects in nursing care. I just put some Google search, so there were nearly 50 million hits what I got just when preparing this about the shortage of nurses. Then, of course, there are special issues at the moment and have been already for 2 years in our different journals about the COVID situation and nursing situation with nurses. And I just want to mention that this one, that was International Nursing Review that was published this year, starting with Annette's actually editorial, launching the editorial here. So it's one example of this kind of research. So I want to, when looking at what's actually the research saying about the situation, I chose to one of the high-level systematic reviews that is on nurses' experiences. And remember, now I'm looking at the nurses' experiences. I wanted to focus on that. So there were 28 articles from 2019, 2021, and the search was really done in a very careful way. So there were articles from 12 countries and over 1,000 nurses were involved in this review. And what was found? Once again, we have evidence that nurses really experienced fear of infection, lack of personal protection equipment, and they don't know, it was unknown, it was uncertain, there was anxiety. They were changed to work in an unfamiliar work environment. You have been maybe working in neonatal unit, you were changed to work in this acute settings. They didn't get any preparation psychologically. They were worrying about their own safety, also their family-related concerns, what we heard already. Then there was the feeling of social isolation, so that there was triggered. They found that it's like a stigma towards the nurses because of the system that they feel that they are working in a hospital. Probably there's some problem with nurses that they will actually infect me. And they felt also different versatile ethical challenges and what were our duties, procedures when we changed to this acute system. And one issue was interesting also, what I found, that what kind of media information they felt that the media was pressing actually a lot, so that there were confusing views about the situation, and the information shared was really sometimes not appropriate. But nurses were also doing some active learning, like coping mechanisms such as active learning, and they were really suggesting that they need for psychological management from organizations and leadership level. And the issue was in this review, what I mentioned, that it is really that this COVID-19 and nursing work should be, this should be understood also for other health professionals, like a traumatic event. And then it would help with the coping or with the occupational, professional, personal stressors. And then I don't know how much time we have. I will just go through this one example from the Nordic country. And this is actually from Finland, and it was just published in Annals of Medicine. And it was just looking at this was the first paper about the anxiety level of hospital workers during COVID-19 pandemic in Finland, one of the Nordic countries. And they used a certain instrument, anxiety disorder instrument, and they had in one area, not in our area, but that was in one of the biggest hospital district areas that they did this survey, and they had nearly 2,000 health workers answering. Most of were nurses, but they had medical experts, other experts like admin, psychologists, dietarians, and so on. So this was also telling the story about the anxiety level. Remember that this was about the anxiety level. So around 55% reported to be having normal level. 30% had mild anxiety and 15% moderate or severe even. And I just wanted to take this single paper because we have this report is the similar as in other, for example, conducted studies in Asian countries. In spite of the case that we didn't have so many cases of COVID in our country to compare to this. So it wasn't actually, the anxiety was not directly associated with the number of COVID-19 patients, or if you were even caring for them. And nurses' anxiety level was higher than physicians. You can tell that they are close to the patients. So key risk factors we found were that there was a younger age, working in a university hospital. There were also community hospitals involved, problems in collaboration with other colleagues, difficulty in concentrating in work, physical and psychological workload, and fear of being infected at work. So I think, can I go through all of these, because I will skip that one, just to come to the conclusions that actually what we heard already is that mental health disorders are really prevalent in the situation, and also the physical health of healthcare workers is at risk. We heard about even the deaths today, the figures. So this is something that we need to take into account. And what is a resilient health work environment for nurses or other health professionals? This is really the question. And I think that we should really press our governments and policymakers to address the mental health burden of healthcare workers and nurses. And as for research, we have a lot of descriptive work, but we should have interventional research, how we can actually change these practices. And this is something that is also, researchers and academians are also, we should have proper funding for that type of research to be able to give or inform our experts on a higher level in a way that in our professional organizations as well as in our national, international networks. So thank you. I will stop to here because I think that I had some literature there too, but thank you, Flora.
Thank you.
It was okay.
Thank you, Professor Katra Vehviläinen-Julkkonen. Thank you so much. Yeah, and also looking at the Q&A questions here, there are no questions so far, but there's a comment from Luker. Inferior nurses do not vaccinate in Germany. I hope that we can do something regarding this aspect, because nurses are really, really qualified to vaccinate people. And so now I will now throw the question to our panel speakers. Should we declare the COVID critical shortage of nurses during COVID-19 as a critical, state of emergency? Who wants to answer first?
I think it is a state of emergency. I don't think there's any need to say, should we? I think it is. And I think it's in a state of emergency for everyone. I think the first thing is invest in your own, grow your own, and in country. Don't be stealing. And I say the word not lightly, stealing from other countries that can ill afford. I don't have a difficulty with nurses going to get better conditions in countries, but we should support them in those countries. And don't call us heroes. As a nurse in Italy said to me some months ago, we were heroes yesterday, we'll be heroes tomorrow. We want to be supported, we want to be protected, we want to be invested. We do not want to be called heroes.
Okay, thank you, Ms. Annette. How about Ms. Elizabeth Iro, who is joining us virtually? Should we declare the shortage as a critical state of emergency? We can't hear Ms. Elizabeth.
Sorry, Flora, just having some technical problem, but I think it's resolved. I think, this is a really difficult and challenging time. And I think, our solutions to retain nurses within the workforce right now, I think it's unacceptable. I think governments and employers need to be really considering seriously the impact of not investing enough into retention of nurses. I think the investment in the education of nurses is also another avenue, but I feel that, as was mentioned, it takes 3 years to graduate a nurse. So the challenge is really doing something about now. How do we keep them in the workforce now? And I think this is heading towards a really challenging time for nurses globally. It's unacceptable.
Yes. How about your opinion, Jim, regarding the question?
Flora, I think we need to look at history as well as the future here. In 2006, the World Health Report described a global crisis in the workforce, including the role of nurses. We went through the Millennium Development Goals and had many calls for the shortage. I mean, you've just seen the data. If you look at the systematic review of literature on this has been with us for decades.
Yeah, that's true.
Mario Monti has just produced his report. To Monti from Italy and on behalf of the European Commission, and that's one of your issues you were talking about, and the World Health Organization in Europe, really questioning the decades of underinvestment in the health and care workforce, including nurses. All the evidence is there. We have to take action. It seems, however, that when it comes to people in the healthcare services rather than disease, maybe it's because the vast majority of these people are women. The government policy and decision makers seem unable to invest in the decent work, the pay, the conditions, the education, the employment to make it done. So I think we have to get a greater awareness. We have to act, not just applaud.
Thank you. Thank you, Jim. And how about Ms. Carla? What do you think about it?
Yes, I think it's every crisis has a chance, and I think there's a lot of attention on this issue, and especially the university clinics can go for a role model. We can change things by educate people by our own, organize career paths, and make it possible that, I repeat the word, decent work conditions are in our clinics. So we offer like work-life balanced shifts, not only working in 3-shift systems, but making it happen that people that have family issues, that they can work at times that are convenient to them. So we change procedures due to the needs of people. And if we are able to change, the academic education to the life and work balanced work orientation, and 3, the continuous learning in order to manage digital tools who will support us to work more efficiently, then I think we can give a role model for others and apply new nurses and keep the ones in the system, which might be crucial for the next 1 or 2 years.
And lastly, from Professor Katri.
Actually, we just heard about from Jim that we have evidence. We have a lot of evidence, but still, so we should implement. And I think that this is something that we also, from a researcher point of view, we need implementation perspective.
Yes, and I think we can entertain just one question. We can extend a little bit because we started at 11. So we can. Do you have any question? The mic is, the floor is yours.
I do. Hi, everyone. My name is Rupa Dodd. I'm the Executive Director of Women in Global Health, also a practicing physician. I have to say this is an amazing panel, great energy. Couldn't agree that without nurses, our health systems will come collapsing. The crisis is real. It's happening now. So my questions is two parts. One is, how do we break out of the echo chamber? Too often these conversations about health workforce shortage, gender equality, the gender dimensions are still happening within the community that's converted, that knows the evidence. Simultaneously, the conversations that took place on the sidelines of the UNGA, including the COVID Global Summit, we saw that health workforce was mentioned maybe less than a quarter of the time. But when we look at the plans our governments are putting forward, they're not talking about real investments in the health workforce. So one, how do we break out of the echo chamber? Second, how do we have much more accountability? And the third, there's been a big call on how do we get an impact investment case? Like what is exact investments needed to keep nurses and the broader global health workforce shortage? And of course, I have to say this must be from a gender lens. Thank you.
Yes, who wants to answer the question from our lady on the floor? You want to answer, Ms. Annette?
Trust you, Rupa, to ask the question. Of course, it has to come from a gender lens. I think that one of the main issues is that we have been seen as carers, and carers by default are unpaid in a high proportion of cases, particularly carers in homes, carers for children, carers for older family members and disabled members. And, you know, it's looked as women can do voluntary work, and it still transfers into the professional areas, which is health, and it does us no service at all. So we have to break out of that area before we will get the equity that we deserve. But in the meantime, it's, I suppose, a gender fight. It's a fight for health of the population, a fight for society. And I think we have to get society talking about what they want in health. Do they want healthcare? Do they want healthcare in communities? Do they want prevention as opposed to treatment? You know, so there's a lot of things that we can do. But I do think that we have to be more, I suppose, strenuous in getting our politicians to realize that there are different models of healthcare. There are models of healthcare that women should be part of. There are models of care that nurses should be involved in relation to decision-making. We haven't been involved in COVID decision-making. We've been the implementers of all the decisions. We have never been involved really in the task force, in the strategic direction or anything else, but we're asked to implement. So we have to start from there.
Yes, unfortunately, we are really running out of time. So if you have some questions, you can send us an email or you can type your comments on the Q&A button. So we will entertain your questions and get back to you as soon as we can. So for just few words, if we are talking about nursing education, we need to not only educate more nursing students, but also nursing trained and competent nursing educators who are actually educating future nurses, our future hope in this planet, so that we can still save the healthcare system. In terms of leadership, we actually need leaders who can actually stand and represent the voice of nurses in healthcare facilities and who can make decisions according to evidence-based. And lastly, one point that we want to make is the remuneration. Give the nurses the salary and remuneration that they deserve. That's a basic fact. And we ask employers to improve the occupational health measures to attend to the physical and mental burnout of our nurses. And I even have heard stories that nurses are wearing diapers in clinical field because they are afraid of changing the PPEs, and they want to save the personal protective equipment. Can you imagine that nurses wearing diapers for 8 hours so they can have a break at all? And this is very unfortunate that this becomes the nursing profession less attractive. And I would just like to leave these few words to you that we are all in danger, actually, if we continue to disregard the value of nursing in the society, in the healthcare system in general. We will continue to see more dead bodies during Corona pandemic times if we don't attend to the needs of our nurses. And in the future, pandemic comes, if there is still pandemic and we don't give the necessary benefits and the necessary measures to attend to our nurses. And I will leave you this one statement, which is used by the Finnish Nurses Association: "The world without nurses, no thanks." So thank you everyone for joining this panel discussion, and especially to our online viewers. And thank you so much, Jim and Miss Elizabeth Iro from who are joining us virtually from the World Health Organization, Miss Annette Kennedy from the International Council of Nurses, Ms. Carla Aiso from the Charité University Hospital, and Professor Katri Vehviläinen-Julkunen from the University of Eastern Finland. My name is Flor Cobello. Thank you so much, and Godspeed to all of you.